Let's move on to the longest section of our colon lecture will be either this as well as the colon polyps and cancer. But this Crohn's and UC is super high yield. So I'm going to break it down for you. I'm going to try to make it easy for everybody to understand because there are a lot of features to this, and it can get confusing to differentiate which feature is part of Crohn's, which is part of UC. So let's break it down. And for this part, I'm going to talk about some of the similarities between Crohn's and UC. So if you haven't already just inferred that from what I'm saying, there are two subtypes of IBD, Crohn's and UC. What happens in both of these diseases is that you have some sort of autoimmune dysregulation that causes inflammation of your GI tract. There's some risk factors. Oftentimes on test, the person who's getting this disease is going to be in their late teens through their 30s. In real life, you can have people with Crohn's who get it in their 60s. There's like a bimodal distribution, but on tests, always consider teens through 30s. It's going to be more common in females, but I don't want you to assume it's just in females. They will test on both. And for race, it's often Caucasian or Jewish descent. And how is this going to present? It's going to present first off with relapsing and remitting symptoms. So you might have a flare up for a couple days to weeks, and then it might go away for a while. You'll be asymptomatic. And the big things to recognize with IBD is you're going to get this abdominal pain. You're going to have diarrhea, oftentimes bloody diarrhea. That's a really good giveaway on tests, and fever. Another thing they love to test about IBD, whether it's Crohn's or UC, is they love to give you a question of somebody who's got these non-specific GI symptoms, and they also have these extraintestinal manifestations. So what kind of extraintestinal manifestations am I talking about? I'm talking about all these inflammatory conditions I listed below. And I'm going to go through each of these really quickly so you have an idea. So here's a picture of uveitis, or inflammation of the uvea. You can have sacroiliitis, which you can see right here on this picture here, inflammation of the sacrum. And you can see aphthous ulcers right here, this gray ulcer with a red bold border, which we actually talked about in our oral cavity section. Two other manifestations that can come up are erythema nodosum, and these are painful lesions in the shins. You can also get this, and I think this is their favorite testable extraintestinal manifestation. It's this pyoderma gangrenosum. And how they like to test this, they like to give you a patient who's got bloody stools and fever, and they show you this, and they say, what do you want to do with it? And some people they'll always be an antibiotic as an option, and that's wrong. This is an autoimmune condition, and this is actually an autoimmune extraintestinal manifestation. So you need to treat it with steroids to actually cure this, to alleviate this condition here. So we've talked about some of the similarities. How I'm going to break this down for your learning pleasure, I'm going to go over each of these features here and go over the differences. So we're going to talk about the location and progression of each of these diseases, how thick the inflammation gets between Crohn's and UC, and we'll talk about a few different findings. I'm going to show you the differences in imaging findings, colonoscopy findings, as well as biopsy findings. And then we'll finish off with different complications that can arise, whether you have Crohn's versus UC. So let's start with Crohn's, and we're going to put those 6 features on and kind of go over what Crohn's looks like, and then I'll do the same with UC so we can differentiate the two. So Crohn's, the location of Crohn's is very interesting. It can pretty much exist anywhere along the GI tract. It doesn't have too much rhyme or reason to it. And I remember this by the mnemonic, Crohn's has no zone. It's not, specific to the distal colon or anything like that. It can be in your oral cavity or what have you. It does have a predilection for one spot, and they love this on tests. They want you to know that Crohn's often affects the terminal ileum and cecum. So if we go here to our diagram and see where exactly this could be, you could have a person with Crohn's who has inflammation in these regions, and that wouldn't be unusual. It's very often to skip sites. And it invades the terminal ileum, which I have in the bottom left there, circled now. And just remember about the terminal ileum when we talked about our small intestine lecture. The terminal ileum is really important for vitamin B12, and because it also is the spot where bile gets reabsorbed. If you have a terminal ileum problem, you can have B12 and fat malabsorption as well. My mnemonic for remembering the locations of Crohn's versus UC, I just take their letter, the C versus the U, and I think about the inflammation being on the I don't know what to call this, like the horseshoe end of the letter. So in this case, if we have a C, the inflammation's kind of at this bulky end here to the left, and that reminds me, okay, it's going to be, if I'm looking at a body here, it's like on the left side of the colon where I'm having all of my inflammation in Crohn's. For the thickness of inflammation, it's really important to realize that Crohn's disease is transmural inflammation, which means it bores through all 4 layers of the GI tract. And I remember this by the mnemonic, Crohn's digs to the bone. It gets all the way through. So if this is our GI tract, we have our lumen, our mucosa, submucosa, our muscular layer, and then our serosa or adventitia. And in Crohn's disease, you have transmural inflammation. So it gets all the way through each of these layers. On imaging, you're going to see a few different things. The first thing you'll see is something called the string sign. So here is an example of the string sign. And what I want you to know, the name kind of speaks for itself, where you can see how there's a lot of these bowels that look like strings. So that's actually the thin intestinal lumen that you can see on imaging studies. And I've highlighted them here. And this actually happens because of intestinal strictures. So if I put our GI tract layers again, what can happen is that if you have inflammation of all these layers, sometimes the inflammation is replaced by scar tissue or connective tissue, and that connective tissue has some contractile abilities. So that connective tissue can actually contract and bring the lumen closer together. And that's what gets you that stricture and that string sign. On colonoscopy, you're going to find a cobblestone appearance. And so you're going to think about the stones in Crohn's. You'll also see creeping fat as well. So let me talk about these really quick. Here's cobblestone mucosa on the, here's cobblestone mucosa on the left here. You can see this kind of looks like a cobblestone pathway. Remember the stones in Crohn's. And you also see this creeping fat here invading. And I just wanted to mention what creeping fat actually is. So creeping fat, oh yeah, how I remember that as well is the CR in creeping fat, the CR in Crohn's. That's a pretty good way to remember it. But I more often, instead of using the mnemonic, I just think about it logically. And how that works is that if you have transmural inflammation, so you have inflammation going through all of the GI tract layers, what can happen now is that the inflammatory cytokines that are released from this transmural inflammation can actually attract the fat and start to bring the fat over. So this fat starts to come over because of this cytokines. And we're not going to see that in ulcerative colitis because we'll find out later that ulcerative colitis only causes inflammation of the first 2 layers. And so there's no cytokine release that can draw this fat into this area in the first place. But if this mnemonic still helps you, the creeping fat and Crohn's, by all means use it. On biopsy, you're going to see something called non-caseating granulomas, which are a Th1 mediated process. Here's some granulomas to the right here. And it's a Th1 mediated immune response. When I think of granulomas, I always think of the granuloma garbage can. It's kind of a garbage can that all of our material that we don't really know what to do with, we just kind of package it up in these big, granulomas, and we just kind of don't even worry about it after that. How I remember this in Crohn's is that I remember that first off, you can do granuloma equals granulona for Crohn's disease. Another way, I think I saw this, I can't remember if it was Dirty Medicine or somebody else who had a pretty good mnemonic about Crohn's and UC. And they basically put Crohn's, instead of Crohn's, they made it Crohn's, like with a 1, to remind you of a Th1 mediated response. so that'll kind of give you an idea that it's granulomas. Either one works, whatever kind of works for you, to remember that these granuloma garbage cans are a histologic hallmark of Crohn's. There's several complications in Crohn's, and I want to go over these to make sure you understand why they are. The last thing I want is for you to have to memorize 5 different complications and just hope that you remember their Crohn's versus UC. It can also cause malabsorption, and you probably have some idea of why that may be because of its location in the terminal ileum. Let's start with strictures, though. We already saw the string sign, so we kind of understand how strictures already work. You have this inflammation, it's transmural, it's replaced by this connective tissue, and boom, you can contract that in, you get a stricture. Abscesses, I don't have a good slide on abscesses, but just know that because it can infect all of the layers of that GI tract, all 4 layers, it's more prone to fistulas, it's more prone to abscesses. It's a little bit more dangerous when it comes to that. Speaking of fistulas, I do have a nice picture on fistulas. A fistula, if you don't remember, is a abnormal passageway between 2 different organs. And the only reason that fistulas are even possible in Crohn's is because they are able to invade all 4 layers. So again, we have invasion of all 4 layers. And now if you have an adjacent organ, what can happen is that inflammation doesn't just stop once it passes through this serosa and adventitia, it continues on to the adjacent organ. And the problem with that is that if you have this continuous inflammation, this area doesn't turn into like this well solidified structure anymore. You can actually get the formation of this passageway between the 2 now, and that can form a fistula. And they do love this on a test. They'll give you somebody who has some of the classic Crohn's symptoms, like, oh yeah, bloody diarrhea, fevers for a long time. And then they'll say something like, this person has also had foul smelling urine with gas in it. And that should make you think, I wonder if it's actually Crohn's because there's some fistula going on between the GI tract and bladder, and stool is actually getting in here and then exiting through the urethra. Moving on, so gallstones and Crohn's is kind of interesting. We haven't talked about gallstones yet, but so I'm gonna go over it just a little bit here. We go into detail in the hepatobiliary section if you need to remember that. What I want you to know for now is that gallstones, bile is a big component of gallstones, okay? And bile I go over in a ton of detail in hepatobiliary. What you need to know right now is that bile is mostly water, but it's got some solutes in it, okay? It's got 4 main things you need to know. It's got bile salts and acids, which actually, I should mention, the bile salts are a pretty good, they reduce the amount of gallstones. They kind of keep everything fluid, so it's actually helpful. If you have a lot of bile salts, you're not going to have as many gallstones. The 2 common offenders for gallstones are cholesterol and bilirubin. And if you get too many of either of these, you can have a cholesterol gallstone form or a bilirubin gallstone. And the 4th category is just this kind of broad other category. It's really low yield. You really just need to know the cholesterol, bilirubin, and then the bile salts. So in the case of cholesterol gallstones, those can form in 2 different ways. You can either get a ton of cholesterol in your bile, which will, supersaturate your bile and predispose you to cholesterol gallstones, or you can have it where your bile salts or acids decrease. Technically, if your water decreases, that can also, so like if you're really dehydrated, you're at risk for both cholesterol and bilirubin stones. But just for this example, this is fine. Either high cholesterol or low bile salts will cause cholesterol gallstones. In Crohn's disease, specifically, you're going to have decreased bile salts and acids, which can increase your risk of cholesterol gallstones. This is from our small intestine lecture, and I just want to point out that if your terminal ileum's not working here, you might get a bile salt deficiency, right? So if you have damage here, you can easily have a deficiency here. And how that works is that in our small intestine, when we're trying to absorb fats, what happens is that as the myceles of fat are absorbed into our enterocytes, the bile that was used to facilitate that process cannot enter these cells. And instead, that bile has to travel all the way down to the terminal ileum, where some of it gets reabsorbed and it can kind of repeat the process over and over. The problem, though, is that if our terminal ileum is damaged in a condition like Crohn's, you're going to lose this ability to reabsorb bile. And so you're not going to get any more bile. And so if that was the case, you'd have an overall deficiency in bile salts and acids, and you can get cholesterol gallstones. Another thing I want to mention with Crohn's disease is nephrolithiasis or kidney stones. So how does that happen? Well, in Crohn's disease, the most common kidney stone you're going to see is calcium oxalate stones. This should be easy to remember because this is the most common kidney stone in the general population too. There's two primary reasons why people with Crohn's are predisposed to these kidney stones. The first is a more general principle. It's if you're dehydrated because of this chronic inflammation, you're going to be more prone to kidney stones, just like you'd actually be more prone to gallstones if you had dehydration. The real thing that they want you to know, the mechanism by which this happens for Crohn's, they want you to realize that there's increased oxalate levels in our bloodstream in Crohn's. So how does that happen? What's going on here? So we just saw this diagram, and we learned that if we have damage to our terminal ileum, we lose this potential and we lose all our bile. The problem is bile was what was helping us absorb all those fat molecules, or break them down at least, right? Emulsify them. And if we don't have that, we're going to have a lot more fat that can't enter our enterocytes. It's just too big. And that fat can start traveling down our GI tract. Note that here, that in our GI tract, we usually have calcium that's bound to oxalate. And if calcium is bound to oxalate, this oxalate can't escape, and this will all get excreted. The problem is that these fat cells love calcium. So they'd be happy now that they're here in the GI tract hanging around. They love to bind to calcium. And when they bind to calcium, calcium loses its grip on these oxalate molecules. And because of that, oxalate's able to freely diffuse into our bloodstream. So you get all this oxalate that's entered into your bloodstream that really wasn't supposed to be there. It was supposed to have just, been excreted, bound to calcium, and nothing would have happened. But with this free oxalate in our bloodstream, you can get calcium oxalate kidney stones. The last thing I want to touch on is malabsorption. So you can get fat malabsorption, fat-soluble vitamin malabsorption, and B12 absorption. So for fat-soluble vitamins, what I want you to remember is that we went over this in the small intestine, but this is just a brief reminder that vitamin A deficiency usually presents with either skin symptoms and eye symptoms. Vitamin D is classically associated with bone problems or hypocalcemia. For vitamin E, really remember that hemolytic anemia. And vitamin K, just remember it's a bleeding risk because you need vitamin K to synthesize several of your clotting factors. And of course, vitamin B12 absorption will be tested on your shelf in the setting of Crohn's disease. This is a picture of our B12 absorption, which I talk about extensively in the stomach and small intestine lectures. What you need to recognize here is that in Crohn's disease, for normal B12 absorption, you need a healthy terminal ileum, and that's because this complex right here gets absorbed at that location. So in Crohn's disease, though, you have a defective terminal ileum, so you don't get this, and that means you lose your B12 in your actual blood, and so you can get a B12 deficiency. So we've talked about the 6 features that I want you to recognize in Crohn's. Now I want to contrast it with ulcerative colitis. So in UC, what I want you to realize is that instead of skipping lesions like Crohn's and kind of having no true rhyme or reason other than the terminal ileum, UC is a lot more logical. It always starts in the rectum, it always involves the rectum, and it continues up proximally. So what that looks like is that the UC will start here, and as the disease progresses, you'll get inflammation here and so forth. And I remember this by thinking of the letter U and realizing that this curved, whatever this horseshoe curve is called, is at the bottom of the U, which reminds me that the progression always starts at the bottom of our body. Instead of Crohn's, where we had the C, which would cause the inflammation to kind of be over here toward the left in the terminal ileum. For the thickness of inflammation, instead of transmural inflammation like we saw in Crohn's, you're going to see it in the mucosa and submucosa. So what that looks like is this region here instead of that transmural inflammation. On imaging, they love this X-ray that shows the lead pipe sign. They're going to test this. What lead pipe colon looks like is a loss of haustral markings on imaging studies. And so here, you can notice in this region here, you have beautiful, healthy colon here. They have their haustra. Remember the haustra are those segmented balls? You can see the subdivisions here. You can see one here and here and here and here. I'm going to draw these lines here so you can kind of see, you know, even here and here still has that nice outline of the haustral markings. In ulcerative colitis, though, you lose these haustral markings. So you end up with this very, like they say, like a lead pipe. This happens because normally, if this is a healthy colon, we have our haustra and our Taenia coli. What's going to happen is that this chronic inflammation here will damage it so much that it loses its definition here. And that's why you get this structure here in the affected colon. If you can imagine the inflammation's kind of coming up here, and causing damage. And that's what's causing all this. And you can see that UC has not progressed to this region here because it still has all of its haustra. On colonoscopy, you're going to see pseudopolyps, which look like this. This is kind of a weak mnemonic, but I remember it as the UC equal. I remember the U in pseudopolyps kind of sounds like UC a little bit. But honestly, I just remember that the stones are in Crohn's and then UC is kind of the other one, if you want me to be honest with you. You don't have to memorize everything. Sometimes it's good to memorize one thing really well and just know that the other one is the other one. On biopsy, you're going to find crypt abscesses, which are Th2 mediated. So on this is a healthy crypt here. Oops. What I want you to realize is that these crypts here are huge and there are a lot of them. If you go into the small intestine lecture, I talk a little bit about the crypts of Lieberkühn and what cells live there. And you can just see that these ones, the abscesses develop in these areas, and that's typical of UC. There's a few complications you got to recognize with ulcerative colitis. The first being colon cancer. You can also get a condition called toxic megacolon. And what I like to refer to as a complication of UC is primary sclerosing cholangitis, which is a hepatobiliary condition. So starting with colon cancer, we'll go into colon cancer in detail. I was looking at the screening guidelines of this. What you need to know is that the longer you've had UC will increase your risk of colon cancer. And because of that, the screening guidelines kind of match that. Right now, here's the colon cancer screening guidelines. If you have a diagnosis of UC, you should have your first colonoscopy 8 years after the diagnosis. There's actually some like leeway, like if you only have a small area affected, you can wait like 12 or 15 years. But if you have like a ton of pancolonic involvement, you should have it done 8 years after your diagnosis. You don't have to remember those numbers, by the way. The important thing you need to know is just this relationship between UC and colon cancer. And here's some other guidelines that this is, like I said, this is not going to be tested, but if somebody does have a diagnosis of UC, you have to get a colonoscopy, and then you have to keep following up with colonoscopies pretty often, every 1 to 2 years. And the big thing you should recognize is that because UC has this gradual progression, if you remove the affected colon regions, you'll actually improve, you'll prevent colon cancer development, and you'll actually cure them of UC. Another complication to keep in mind is toxic megacolon. So toxic megacolon is caused by inflammation because of damage to nerves in the myenteric plexus related to that chronic inflammation. Because of these damage to the myenteric plexus nerves, you're going to get a decrease or absence of peristalsis, which is our normal movement of our stool burden throughout our GI tract. So remember, we have our lumen, mucosa, submucosa, our muscular layer, and our serosa or adventitia. In our third layer, our muscular layer, we have a few important structures. We have our inner circular muscle layer. We have our myenteric plexus, also known as Auerbach's plexus. And how I remember its functions, I remember the M in myenteric for the M in movement. So that reminds me that, okay, this is causing the myenteric plexus is important for movement or peristalsis. And just remember, you have an outer muscle layer here. And one more thing I like to point out every time we talk about the myenteric plexus is that it also regulates sphincter tone. And that's why achalasia, when we talked about in the esophagus lecture, is also a myenteric plexus problem. So remember, it regulates peristaltic contraction. So if you don't have peristalsis, this region here is not having any peristalsis. It's nothing's going right here. Nothing's moving along. So what's going to happen is that right here, proximal to that, everything's going to back up. So even though this looks like the worst area because it's all big, this is actually the area that's affected, if that makes sense. The normal appearing area is the area that's already been damaged so much that it can't propel food into this region, so it just backs up proximal. And this thing, as you can see, it's already getting bigger and bigger. This thing can easily perforate, and that's a surgical emergency. And so you can get abdominal pain, abdominal distension. You could obviously be in shock and be acutely dying, basically, if this perforates. And you got to treat this with a few different things. You can do decompression or steroids. And of course, like we said a couple times now, sometimes surgery is the best option for something like this. The last thing I want to talk about is primary sclerosing cholangitis. I talk about this in the hepatobiliary lecture, but I do want you to think about it as a complication of UC instead of its own disease entity, because I think it's easy to remember some of the features of both UC and PSC if you consider it that way. As you can see, this is from the hepatobiliary slide. I just want you to point out that if we think about it as a complication, we'll realize that 90% of people have IBD. And then it has some of the same symptoms. So I'll show you what I mean. I think of PSC like this. You have your inflammation, it grows, it grows, it grows, and it just keeps growing, and it finally reaches your bile ducts here. That's in my head. This isn't really what happens all the time or anything like that, but in my head, this is how I think about it. And if you think about it like that, you'll realize why 90% of people with PSC end up having an inflammatory bowel disease. So it sounds like a complication. And you'll also notice that in PSC, you'll often, especially on tests, they love to, I haven't seen a primary sclerosing cholangitis that was not a complication of IBD yet on step 1 or any of the practice exams. If you'll always see somebody who has some sort of UC symptoms as well. Okay. And here is PSC. I go over this in great detail in the hepatobiliary. I just want you to notice that even if you look at the lab values of PSC, we'll talk about P-ANCA later. That's a common laboratory findings in ulcerative colitis. You also see that in PSC. A few other things I want to differentiate between Crohn's and UC. I want you to realize that cigarette smoking is actually protective against UC, but not against Crohn's. And I just remember the UC as you can smoke. And laboratory findings, I just alluded to this on the slides with PSC. So for Crohn's, you can get a positive ASCA antibody or anti-Saccharomyces cerevisiae antibody. And in UC, you can get a positive P-ANCA antibody. For treatment of Crohn's and UC, you do not need to know the treatment algorithm. All you need to know is some of the side effects, and it's nice to at least have been exposed to some of these drugs because they will sometimes be like, "Hey, somebody has Crohn. What do you treat them with?" And they'll just give you one of these drugs. So you don't need to know this entire algorithm, but it's good to know some stuff. A good place to start is with mesalamine, which is basically aspirin that is activated in your colon. You can also try steroids, which is very common. Makes sense if it's an autoimmune condition. And then after here, there's a few different algorithms that show different things. I liked one of the algorithms that basically said, hey, if your steroids worked out, you can give them kind of a low dose immunosuppressant, um, azathioprine. Sorry, I can't speak right now. And then if the steroids really didn't work out as well, then you can move up to like a TNF alpha inhibitor like infliximab. Again, I think I've seen people on TNF alpha inhibitors, even though they had a good response to steroids. So take this algorithm with a grain of salt. And then if everything fails, if nothing's working, you can kind of go to cyclosporin, which is more of a heavy hitter. The only reason I put this algorithm on is because it allows us to talk about 5 different classes of medications, and they do test those at times. They'll give you somebody with IBD who's on who's on a medication, and they'll either give you the medication and ask for the side effects, or they'll give you a patient who has IBD and they have all these side effects, and then they make you answer what medication are they taking. So the side effects you need to know is for mesalamine, you need to know all that it can cause bleeding because it's an NSAID, and it can cause GI side effects as well. For corticosteroids, just remember its associations with psychosis, high blood pressure, high sugar levels, and Cushing syndrome. Azathioprine, it's tested more often than it should be, that if you give azathioprine with something like allopurinol, you can actually get toxicity. And the reason why this happens, if we have azathioprine here, it's actually degraded into 6-mercaptopurine, which is also a known agent in itself that you can prescribe. And then this gets degraded into an inactive metabolite. Now, this degradation here is performed by an enzyme called xanthine oxidase. The problem is if you have somebody who has like gout, let's say, and you give them a xanthine oxidase inhibitor, you can cause some issues, because if we inhibit this enzyme, we can no longer inactivate 6-mercaptopurine or azathioprine. So these will get very big, and so you can get dangerously high levels of azathioprine if you give this in conjunction with a xanthine oxidase inhibitor. TNF alpha inhibitors, you need to know that because these are immunosuppressants, they could reactivate TB or hepatitis. So you should always order TB testing and hepatitis screen before you begin these therapies. And cyclosporin, you just need to know that it's a nephrotoxic and neurotoxic. You also need to know for step 1 that it's a type of calcineurin inhibitor, which I actually had to look up before making this lecture because that's how low yield that last statement was. Okay, I just have 20 more facts that I really want to give you about Crohn's and UC. No, I'm just messing with you guys. You guys did great. That was a tough section.
Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.